Number 1. Maternal serum alpha-fetoprotein, or MSAFP. This is your screening test for chromosomal and neural tube defects. If you see a low AFP paired with a low estriol and a high HCG, think possible chromosomal abnormality like Down syndrome. If the AFP is high after 15 weeks, that points you toward a neural tube defect. Always know how to interpret that panel because NCLEX loves to slip it in. Number 2. Naegele's rule. You'll be asked over and over, how do you calculate a due date? Subtract 3 months from the first day of the last menstrual period and add 7 days. For example, if the LMP was June 10th, due date is March 17th. Straightforward, but don't forget the year flip. Number 3. Presumptive, probable, and positive signs of pregnancy. Presumptive signs are what the patient reports: nausea, breast tenderness, amenorrhea. Probable signs are objective findings like a positive pregnancy test or Goodell's sign. But only 3 things are truly positive. You hear the fetal heart tones, you see the fetus on ultrasound, or you palpate fetal movement. Everything else is a maybe. Number 4. Weight gain in pregnancy. The expected gain is about 25 to 35 pounds total. Break it down. About 3 to 5 pounds in the first trimester, then roughly a pound a week in the second and third trimesters. If you see rapid gain, especially with swelling, that's not good. Think preeclampsia. Number 5. Nutrition in pregnancy. Folic acid is the star here, 400 to 800 micrograms daily to prevent neural tube defects. Increase iron, calcium, and protein. Avoid raw fish, deli meats, unpasteurized dairy, and no more than 200 milligrams of caffeine a day. Number 6. Nausea and vomiting management. The practical tip: small, frequent meals, dry crackers before getting out of bed, avoid greasy or spicy foods, and ginger or vitamin B6 can help. If the vomiting is severe, weight loss, dehydration, that's hyperemesis gravidarum, and that needs IV fluids and electrolytes. Number 7. Common discomforts. Fatigue in the first trimester, urinary frequency from the uterus pressing on the bladder, heartburn, and constipation from progesterone relaxing smooth muscle. Teach lifestyle fixes: elevate legs for edema, fiber and fluids for constipation, supportive bra for breast tenderness. Number 8. Warning signs in pregnancy. Any vaginal bleeding, severe headache, vision changes, swelling of face or hands, decreased fetal movement, or sudden gush of fluid. These are never normal and should be reported immediately. Number 9. Gestational diabetes screening. The 1-hour glucose tolerance test is done between 24 and 28 weeks. If abnormal, follow with a 3-hour test. Remember, untreated gestational diabetes increases risk for macrosomia, hypoglycemia in the newborn, and respiratory distress. Number 10. Quickening. This is when the mother first feels fetal movement, usually around 16 to 20 weeks in a first pregnancy, sometimes a little earlier if she's had babies before. Number 11. Danger signs of pregnancy to never ignore: severe abdominal pain, vaginal bleeding, absence of fetal movement, or swelling with headache. These always require evaluation. Number 12. Placenta previa versus placental abruption. Previa equals painless, bright red bleeding in the third trimester. Abruption equals painful, dark red bleeding with a rigid uterus. Management is completely different, so don't mix them up. Number 13. Ectopic pregnancy. Suspect it when there's unilateral pain, missed period, and light bleeding. If it ruptures, the patient may show signs of shock. Methotrexate can be used if diagnosed early, otherwise surgery is required. Number 14. Hydatidiform mole. This is a molar pregnancy, abnormal trophoblastic growth. Signs: very high HCG, snowstorm. Ultrasound: uterine size greater than dates, severe nausea. After evacuation, HCG levels are followed for a year, and pregnancy must be avoided during that time. Number 15. Infections in pregnancy. Torch infections, toxoplasmosis, other like syphilis, rubella, cytomegalovirus, herpes. They can cause fetal anomalies. Avoid cat litter, toxoplasmosis, and remember rubella vaccine is contraindicated during pregnancy but given postpartum. Number 16. Immunizations. Safe: Tdap, flu shot, hepatitis B. Unsafe: MMR, varicella, live vaccines. Number 17. Rh factor. Rh-negative mothers get RhoGAM at 28 weeks and again within 72 hours postpartum if the baby is Rh positive. Also after any event with possible blood mixing like amniocentesis or miscarriage. Number 18. Group B strep screening. All women are screened between 35 and 37 weeks. If positive, treat with IV penicillin during labor to protect the baby from sepsis and pneumonia. Number 19, fetal heart tones. Normal baseline is 110 to 160 beats per minute. Bradycardia equals less than 110, tachycardia equals over 160. Variability is good. It means the baby has an intact nervous system. Number 20, fundal height. After 20 weeks, fundal height in centimeters should roughly equal weeks of gestation. If 28 weeks, fundus about 28 centimeters. If way off, think growth restriction or polyhydramnios. Number 21, ultrasound uses. First trimester, confirm pregnancy, dating, and viability. Second trimester, anatomy scan. Third trimester, growth and position. Non-stress test and biophysical profile assess well-being. Number 22, amniocentesis. Before 20 weeks, it's mainly for genetic testing. After 35 weeks, it can check fetal lung maturity. Risks: infection, rupture of membranes, Rh isoimmunization. Number 23, non-stress test. Reactive is what you want, at least 2 accelerations of 15 beats for 15 seconds in 20 minutes. Non-reactive needs follow-up with a biophysical profile. Number 24, contraction stress test. Negative is good, no late decelerations with contractions. Positive shows late decels and indicates uteroplacental insufficiency. Number 25, biophysical profile. Looks at 5 things: breathing, movement, tone, amniotic fluid, and non-stress test. Each scored 2 points. A score of 8 to 10 is reassuring. Number 26, kick counts. Mother should feel about 10 movements in 2 hours. If fewer, she should come in for evaluation. Number 27, signs of preterm labor. Regular contractions every 10 minutes or less, backache, pelvic pressure, and changes in vaginal discharge. Tell patients to call immediately if these occur before 37 weeks. Number 28, teratogenic medications. ACE inhibitors, warfarin, isotretinoin, certain anticonvulsants. Always check meds for pregnancy safety categories. Number 29, pregnancy categories. Know the difference. Category A is safe, Category X is contraindicated. Most drugs fall in the gray middle. Number 30, physiological anemia of pregnancy. Plasma volume increases more than red cell mass, so hemoglobin and hematocrit appear lower. It's normal unless hemoglobin falls below about 10.5 in the second trimester. Number 31, supine hypotensive syndrome. When the uterus compresses the vena cava, the woman gets dizzy, pale, hypotensive. Solution: put her on her left side. Number 32, prenatal visit schedule. Every 4 weeks until 28 weeks. Every 2 weeks until 36 weeks, then weekly until delivery. Example: if she's 32 weeks and came in today, her next visit is in 2 weeks. Number 33, amniotomy care. The very first nursing action after rupture of membranes, whether it's spontaneous or artificial, is to check the fetal heart rate. Why? Because the cord can prolapse, and you'll pick it up first on the monitor. Don't just write down the color of the fluid and walk away. The heart rate is priority. Number 34, variable decelerations. These are those sharp V-shaped dips in fetal heart rate, usually caused by cord compression. The immediate intervention is to reposition the mother, often into a slight Trendelenburg or knee-chest position, to relieve pressure on the cord. Number 35, early decelerations. These mirror the contractions, and they're due to head compression. They're benign, just document. No intervention is needed. Number 36, late decelerations. These occur after the contraction has started and recover after it's over. They signal uteroplacental insufficiency. Nursing actions: reposition to the left side, give oxygen, increase IV fluids, stop oxytocin, and notify the provider. Number 37, oxytocin for induction or augmentation. Always use an infusion pump. Start low, titrate slowly. Watch for tachysystole, more than 5 contractions in 10 minutes. If that happens, stop the oxytocin immediately. Number 38, Bishop score. This is how we measure cervical readiness for induction. You look at dilation, effacement, station, consistency, and position. A score of 8 or higher usually predicts successful induction. Number 39, stages of labor. First stage is onset of contractions until complete dilation. Second stage is complete dilation to delivery of the baby. Third stage is delivery of the placenta. Fourth stage is the immediate postpartum recovery, about the first 1 to 2 hours after birth. Number 40, phases of the first stage. Latent phase, 0 to 3 centimeters, contractions mild and irregular. Active phase, 4 to 7 centimeters, contractions stronger and more regular. Transition, 8 to 10 centimeters, contractions every 2 to 3 minutes, lasting 60 to 90 seconds. Very intense. Number 41, signs of true labor versus false labor. True labor contractions get stronger, closer together, and cause cervical change. False labor, Braxton Hicks, are irregular, don't intensify, and resolve with rest or hydration. Number 42, signs of imminent delivery. A sudden urge to push, rectal pressure, and bulging perineum. Especially in a multigravida, don't ignore this. Delivery can happen quickly. Number 43, prolapsed umbilical cord. This is an obstetric emergency. You'll see or feel the cord or notice sudden severe variable decelerations. Nursing actions, call for help, insert 2 sterile gloved fingers to lift the presenting part off the cord, place mother in knee, chest, or Trendelenburg, and prepare for immediate delivery. Number 44, placenta previa versus placental abruption. Again, but from the intrapartum perspective. Placenta previa presents with painless, bright red bleeding. Placental abruption is painful, with uterine tenderness and a firm, board-like abdomen. Previa means no vaginal exams until location is confirmed by ultrasound. Number 45, uterine rupture. Signs: sudden tearing abdominal pain, loss of fetal station, abnormal fetal heart rate, maternal shock. This is rare but catastrophic, requires emergency surgery. Number 46, pain management with opioids. Butorphanol and nalbuphine are examples. They can cause respiratory depression in the newborn if given close to delivery. Best time to give them, during active labor, well before delivery. Number 47, epidural anesthesia. Main nursing actions: preload with IV fluids to prevent hypotension, monitor blood pressure frequently, and keep patient on her side to promote placental perfusion. If hypotension occurs, give fluids, reposition, and oxygen. Number 48, pudendal block. This is local anesthesia injected into the pudendal nerve, used late in the second stage for forceps delivery or repair. It doesn't affect contractions, just numbs the perineum. Number 49, general anesthesia. Rarely used for vaginal delivery, usually for emergency C-section. Risks: aspiration, neonatal respiratory depression. Number 50, non-pharmacologic pain relief. Breathing techniques, relaxation, massage, hydrotherapy, positioning. These are safe and effective, especially in early labor. Number 51, hyperventilation during labor. If a patient is breathing too rapidly, she'll complain of lightheadedness, tingling, or numbness. Intervention: have her breathe into a paper bag or cupped hands to rebreathe CO2. Number 52, uterine atony prevention after delivery. Fundal massage is the key intervention. Oxytocin is often given routinely to keep the uterus firm and prevent hemorrhage. Number 53, lacerations and episiotomies. Degrees range from 1st degree, just the mucosa, up to 4th degree, which extends through the rectal mucosa. Assess for hematomas, swelling, and bleeding postpartum. Number 54, cesarean section priorities. Pre-op, consent, NPO, IV fluids, prophylactic antibiotics. Post-op, monitor incision, lochia, bowel sounds, pain, and signs of infection or hemorrhage. Encourage early ambulation to prevent clots. Number 55, induction preparation. Gather amniotomy hook if membranes are to be ruptured, IV fluids like D5LR, and oxytocin infusion pump. Anticipate the need for close fetal monitoring throughout. Number 56, Lochia progression. After delivery, vaginal discharge follows a pattern. Lochia rubra is bright red, lasting about 3 days. Lochia serosa is pink or brown from days 4 through 10. Lochia alba is white or yellow, lasting up to 6 weeks. If the flow goes backward in color or has a foul odor, think infection or retained products. Number 57, uterine involution. The fundus should be firm, midline, and descend about 1 centimeter per day. By 2 weeks, it should no longer be palpable abdominally. A boggy uterus means atony, which is the leading cause of postpartum hemorrhage. Massage immediately. Number 58, postpartum blues. Tearfulness, mood swings, anxiety, and irritability are common in the first 1 to 2 weeks after birth. This resolves on its own. If symptoms persist beyond 2 weeks or worsen, that's postpartum depression and requires evaluation. Number 59, circumcision care. Apply petroleum jelly to the glands with each diaper change for the first few days. A yellow exudate on the tip is normal healing, not infection. Watch for excessive bleeding or lack of urination. Number 60, engorgement management. Encourage frequent breastfeeding every 2 to 3 hours. Apply warm compresses or shower before feeds to soften the breast, and cold compresses after feeds for comfort. For bottle-feeding mothers, use tight-fitting bra, ice, and avoid stimulation. Number 61, nipple soreness. Correct positioning and latch are key. Express a little milk and let it dry on the nipple. Use lanolin cream and rotate feeding positions. Number 62. Risk factors for postpartum hemorrhage: grand multiparity, multiple gestation, prolonged labor, use of oxytocin, operative delivery, and history of hemorrhage. Always assess those patients closely. Number 63. Constipation due to progesterone, decreased motility, and fear of pain. Encourage fluids, fiber, ambulation, and stool softeners. Number 64. Diabetes postpartum. Insulin needs often decrease suddenly after the placenta is delivered because placental hormones antagonize insulin during pregnancy. Monitor blood sugars closely. Number 65. Rubella vaccination. Given postpartum if the mother is non-immune. She should avoid pregnancy for at least 1 month after because it's a live vaccine. Safe to breastfeed. Number 66. Birth control counseling. Estrogen-containing methods are avoided in breastfeeding mothers because they can decrease milk supply. Progestin-only methods, IUDs, and barrier methods are preferred. Number 67. Care after intrauterine fetal demise. Provide emotional support. Offer parents time with the baby, pictures, footprints, and a memory box. Acknowledge their grief and avoid cliches. Number 68. Postpartum infection. Watch for fever, foul-smelling lochia, uterine tenderness, or wound erythema. Common causes are endometritis, mastitis, or urinary tract infection. Treat promptly with antibiotics. Number 69. Postpartum follow-up. Routine checkup is at 6 weeks, but patients should be instructed to call sooner for heavy bleeding, fever, severe pain, or signs of depression. Number 70. Vernix caseosa. This is the white, cheesy substance found in skin folds at birth. It's protective, and it usually decreases as gestation advances. Number 71. Meconium. The first stool, black and tarry. Passage within the first 24 hours is normal. Delayed passage could indicate Hirschsprung disease or cystic fibrosis. Number 72. Pseudostrabismus. Crossed eyes are common in newborns because of immature ocular muscles. This usually resolves by 3 to 4 months. Number 73. Head molding. The skull bones overlap during birth. This is normal and resolves in a few days. Number 74. Cephalohematoma versus caput succedaneum. Cephalohematoma is bleeding under the periosteum, does not cross suture lines, and resolves over weeks. Caput succedaneum is soft tissue swelling that crosses suture lines and resolves in a few days. Number 75. Adequate breastfeeding. You know the baby is getting enough if there are 6 to 8 wet diapers per day, steady weight gain, and satiety after feeds. Number 76. Umbilical cord care. Keep it clean and dry. It falls off within 1 to 2 weeks. Report redness, swelling, or drainage. Number 77. Emergency delivery priorities. After birth, dry the baby, place skin to skin with the mother, stimulate breathing if needed, and start breastfeeding right away. Early breastfeeding also helps reduce maternal hemorrhage. Number 78. Helping a baby who won't latch. Encourage skin-to-skin contact, express a little milk to stimulate flow, and try different positions. If persistent, involve a lactation consultant. Number 79. Fontanelle closure. The anterior fontanelle closes by 12 to 18 months. The posterior fontanelle closes by 6 to 8 weeks. Number 80. Hypoglycemia in newborns. Signs include jitteriness, weak cry, lethargy, and hypothermia. Babies of diabetic mothers are especially at risk. Check blood glucose promptly. Number 81. Pathological jaundice. Jaundice appearing within the first 24 hours is abnormal and suggests hemolysis. This requires immediate evaluation and treatment to prevent kernicterus. Number 82. Milia. Tiny white papules on the nose and cheeks. They're benign and require no treatment. Number 83. Newborn medications. Vitamin K IM to prevent hemorrhagic disease, erythromycin eye ointment to prevent gonococcal infection, and hepatitis B vaccine as part of the immunization series. Number 84. Term infant gestation. A normal term is 39 to 40 weeks. Post-term is beyond 42 weeks. Post-term infants are at risk for meconium aspiration and hypoglycemia. Number 85. Immediate newborn care. Within the first 30 minutes, focus on airway, breathing, circulation, thermoregulation, and APGAR scoring at 1 and 5 minutes. Number 86. Infants of diabetic mothers. Risks include hypoglycemia, respiratory distress, congenital anomalies, and macrosomia. Monitor closely after birth. Number 87. Induction considerations for diabetic mothers. Strict glucose control during labor reduces neonatal hypoglycemia. Insulin requirements drop sharply postpartum. Number 88. Babies born to hepatitis B positive mothers. They receive both the hepatitis B vaccine and hepatitis B immune globulin within 12 hours of birth for protection. 89. Client teaching success. The number one factor that determines if your teaching works is the client's readiness to learn. If she's not ready, even the best teaching won't stick. Number 90. Maternal-infant bonding. Signs include eye contact, touching, holding the baby close, and responding to the infant's needs. Encourage rooming in and skin-to-skin contact. Number 91. Timing of childbirth classes. These are usually offered in the second trimester, so parents are prepared before the final weeks. Number 92. Edema in pregnancy. Common in the lower extremities due to venous stasis. Encourage the mother to elevate her legs, avoid prolonged standing, and sleep on her left side. Generalized edema, especially of the face and hands, is a warning sign for preeclampsia. Number 93. Signs of preeclampsia: hypertension, proteinuria, headache, visual changes, and epigastric pain. Epigastric pain is particularly concerning. It can signal impending seizure. Number 94. Pica. This is craving and eating non-food substances like clay or starch. It's associated with iron deficiency anemia. Number 95. Neonatal respiratory distress scoring. The Silverman-Anderson score assesses chest movement, retractions, and grunting. Lower scores mean better respiratory status. Number 96. Cephalopelvic disproportion. When the baby's head is too large or the mother's pelvis too small for vaginal delivery. This may require a C-section. Number 97. Rh sensitization. If the mother is Rh negative and exposed to Rh positive blood, antibodies form and attack the next baby. Prevention is with RhoGAM. Number 98. Prenatal visit schedule. Again for emphasis. Every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, then weekly until delivery. Always tie this to safe prenatal care. Number 99. Breastfeeding education. Teach early initiation, demand feeding every 2 to 3 hours, and avoidance of pacifiers in the early weeks to prevent nipple confusion. Number 100. Fetal heart variability. Moderate variability is good. Minimal or absent variability could mean hypoxia or effects of medication. Interventions include oxygen, repositioning, and fluids. Number 101. Leopold's maneuvers. These are abdominal palpations used to determine fetal position, presentation, and lie, critical for identifying breech or transverse before labor. Number 102. Preparing labor supplies. For hospital births, gather admission papers, IV access supplies, oxytocin, and equipment for fetal monitoring. Number 103. Pelvic structure. The gynecoid pelvis is most favorable for vaginal delivery. Android, anthropoid, and platypeloid can present more challenges. Number 104. Indigestion and reflux in pregnancy. Due to progesterone and upward displacement of the stomach. Teach small meals, avoid lying flat after eating, and sit upright. Number 105. Supine hypotension. Again for emphasis, avoid lying flat on the back. Left lateral positioning is safest for perfusion. Number 106. Braxton Hicks contractions. These are irregular and don't cause cervical change. True labor contractions get stronger, closer, and more regular. Number 107. GT-PAL system. Gravida is total pregnancies. Term is pregnancies delivered at 37 weeks or beyond. Preterm is before 37 weeks. Abortions include miscarriage and termination before 20 weeks. Living is number of living children. Number 108. Fetal circulation. Key structures are the ductus arteriosus, ductus venosus, and foramen ovale. These close after birth when the baby starts breathing and circulation shifts. Number 109. Rupture of membranes. Assess the color, odor, and amount. Green fluid means meconium. Always check fetal heart tones after rupture. Number 110. Preterm labor interventions. Bed rest is no longer routinely recommended, but medications like tocolytics, corticosteroids for lung maturity, and magnesium sulfate for neuroprotection may be used. Number 111. Hypertensive disorders of pregnancy. Gestational hypertension, preeclampsia, eclampsia, and HELP syndrome. HELP stands for hemolysis, elevated liver enzymes, and low platelets. Always dangerous. Number 112. Maternal positioning in labor. Upright positions help progress labor, reduce pain, and promote fetal descent. Supine is the least favorable. Number 113. Oxygen administration in labor. Give by non-rebreather mask at 8 to 10 liters per minute when indicated. Don't use nasal cannula, it's not enough. Number 114. Magnesium sulfate, used for seizure prevention in preeclampsia. Monitor reflexes, respiratory rate, and urine output. Antidote is calcium gluconate. Number 115, betamethasone, given to mothers at risk of preterm delivery to accelerate fetal lung maturity, usually given in 2 doses, 24 hours apart. Number 116, tocolytics. Medications like terbutaline or nifedipine are used to stop contractions. Watch for side effects like tachycardia and hypotension. Number 117, patient education at discharge. Cover warning signs: heavy bleeding, fever, severe headache, chest pain, or depression. Reinforce follow-up visits, contraception, and breastfeeding support.